Okay. Can everyone hear me?
Yep.
Why don't you introduce yourself a little bit and where you're from, and just a little bit.
Okay. Good morning, everyone. Dr. Nadia Mazloom. I'm here in Washington, D.C. with AMIQT. I'm from Atlanta, Georgia. I graduated from United Arab Emirates, and I've been on this rotation now this is the 4th week with Dr. Bernad. So I'll be speaking today on peripheral neuropathy. And the reason I chose this topic is because it is quite common. We see it fairly regularly in clinical practice. And I think because it is so common, we can sometimes neglect the complexities of it. So what we're going to talk about, what is peripheral neuropathy, the different etiologies that can lead to it, how prevalent it is, the epidemiology, pathophysiology, and then how to approach a patient who has suspected peripheral neuropathy. So what is it? It's basically damage to a peripheral nerve, mononeuropathy, or nerves, poly or multifocal neuropathy due to injury or an underlying disease process. And it is quite common. It affects about 2.4% of the population, but as the age increases, the prevalence increases to closer to around 8%. And the most common of the generalized polyneuropathies is the diabetic sensory-motor polyneuropathy, which may be present in as many as 66% of type 1 diabetics and almost 59% of type 2 diabetics. And the prevalence may actually be even higher depending on the criteria that they're using to diagnose the peripheral neuropathy. And since the prevalence of diabetes is about 1.3%, it is estimated to affect nearly 1% of the general population. The most common genetic sensory-motor polyneuropathy is the Charcot-Marie-Tooth disease, and its prevalence is around 30 per 100,000. And then something we all know quite commonly is carpal tunnel syndrome, which is the entrapment of the median nerve. It's the most common mononeuropathy, and its prevalence is estimated between 3 and 5% of adults. Okay, so this list is by no means all-inclusive. This is just to give you the idea that there are many causes of peripheral neuropathy. The most common, of course, is diabetes, the diabetic neuropathy, and it's what we see most commonly. But there are many causes. The mononeuropathies, things like carpal tunnel syndrome, piriformis syndrome, tarsal tunnel syndrome. And then in the polyneuropathies, they are grouped by hereditary disorders like the Charcot-Marie that we mentioned earlier, inflammatory like Guillain-Barré, vasculitis. Infectious diseases can also cause it, though not as common, things like leprosy and HIV. And then you have the systemic diseases with like diabetes, paraneoplastic syndrome, paraproteinemia. And then of course, there's always drugs and toxins. Chemotherapeutic agents have been known to cause polyneuropathy, isoniazid, alcohol, as well as some heavy metal poisonings as well. So although there are many etiologies to peripheral neuropathy,
There's one other big group that I think we should mention.
Mm-hmm.
These are the autoimmune.
Autoimmune, yes.
We're becoming more aware of those. We didn't think about them in the past as much, but go ahead.
Okay. So although we have several different etiologies, there are only a few pathological responses of the nerves to these insults. We have, this is the normal, you have the nerve body cell, the axon with the myelin on the outside. Oh, sorry. So in Wallerian degeneration, the axon actually degenerates distal to a focal lesion that disrupts the continuity of the axon. And this is usually in focal mononeuropathies after trauma or a nerve infarction. Then we have axonal degeneration, which is also called the dying back phenomenon. And that's when you have axonal degeneration at the most distal extent of the axon. These are usually symmetrical, and as it progresses, they usually degenerate in a distal to proximal gradient. And this is the most common pathological reaction in generalized polyneuropathies, and it's usually due to a metabolic cause. And finally, we have segmental demyelination, and that's when you have focal degeneration of the myelin sheath with sparing of the axon itself. So this is seen in focal mononeuropathies and in generalized sensory motor or predominantly motor neuropathies. Acquired segmental demyelinating polyneuropathies are usually immune-mediated or inflammatory, but it may also occur in hereditary polyneuropathies. So basically, recovery in etiologies that involve the segmental demyelination are usually a lot faster compared to the Wallerian or axonal, and that's just because remyelination can occur much faster than axon regeneration. So we see these patients all the time. They come in complaining of things like tingling, numbness, burning sensation, pain, weakness, decreased ability to feel temperature changes, increased sensitivity to touch. We even had a patient who couldn't stand the bed sheets touching their legs. It caused them extreme pain. So this is, I found this and I thought it was quite interesting, a quite interesting approach, a way to kind of group these differential diagnoses when you're dealing with a patient that presents with peripheral neuropathy or a suspected peripheral neuropathy. And the most important point, as with any patient, is to take a detailed history. You're going to want to make sure to talk about the time course and evolution. When did it start? How is it going? Is it getting worse? Is it staying the same? Family history, when you're looking for those hereditary polyneuropathies. Do they have any other family members that have these diseases? You want to ask about their pain, fever, night sweats, and weight loss, looking at more of a hematological or oncological underlying etiology. And then you want to ask about exposure to medications, alcohol, heavy metals, any industrial chemicals, things like that. And then, of course, diabetes. And the patients may not know they have diabetes. They may not yet have been diagnosed with diabetes. So it's important to make sure to ask those questions when you're taking the history. And then, of course, your neurological examination can help you determine the type of nerve fiber involvement, whether it's sensory, motor, or autonomous. And then you want to make sure to pay attention to the distribution. Is it distal symmetric, proximal, asymmetric, multifocal? This is all going to help you establish your differential diagnoses, which will then help guide you with your appropriate testing. So as we see, once we ask those questions, we can group these based on the patterns. You have slowly progressive, distal symmetric, sensory predominant. You want to think of causes like diabetes, CIAP, alcohol, chemotherapy. Pattern 2, which is a more slowly progressive, long wasting, they have muscle wasting, foot abnormalities. You want to think more along the lines of hereditary or again, CIAP. With pattern 3, we have subacute onset with and or proximal motor involvement. Now with these, you want to think of vasculitis, paraneoplastic, diabetic plexopathy, and things of that nature. If they're having more subacute, rapidly progressive with painful autonomic dysfunction, you want to think of things like Guillain-Barré, vasculitis, and again, paraneoplastic syndrome. And lastly, sensory ataxia, loss of proprioception, and pseudoapoptosis. You want to think more along the lines of immune-mediated things like Sjogren's, paraneoplastic syndromes. And as you see, there is some overlap in these patterns. So it won't always give you a clear picture, but it can always help to guide you. So this next one, I know it's a lot. I'm not going to go through each one. This is just basically reinforcing the point that based on your differential diagnoses, you're going to do different tests to work up the underlying etiology, whether you're going to do a CBC, or you're going to test for heavy metal poisoning, or you're going to do toxicology, or you're going to do thyroid tests or anything like that, genetic testing. So again, really important to do a really thorough history and physical examination. To diagnose the neuropathy itself, we have things like the nerve conduction studies and needle electromyography. And you can do these to confirm that it is in fact a peripheral neuropathy. You can rule out other differentials like radiculopathies, distal neuropathies. And sometimes if you have a high suspicion that there's subclinical nerve involvement, maybe the patient's not having frank symptoms and you wanted to see if they were in fact having any nerve issues, these tests would be useful. And you can also use these to establish the severity of the disease. I'm just going to talk about the screening for 1 second for diabetes, since it is the most common cause. It's very important that diabetics have an annual screening for diabetic neuropathy, and it should be conducted by superficial pain sensation testing, SWME, or vibration testing. And these, along with positive findings on your physical exam, can predict the likelihood of neuropathy in your patient. So how do we manage these? So basically the main management is aimed at the underlying etiology. So for example, in your diabetic neuropathy, glycemic control is the aim, and you can stabilize and even improve the neuropathy in these patients. Hereditary neuropathy, you're going to do things like family genetic counseling, education, screening of other family members. And then with your immune-mediated neuropathies, they're usually managed with very specific immune modulating therapies, like in GBS, we have IVIG and plasmapheresis. We have supportive measures, things like physical therapy, bracing, ambulation aids, anything that's going to help the patient in their daily life. And of course, pain management, which is very important because a great deal of these patients suffer with a lot of pain. NSAIDs are usually ineffective when it comes to neuropathic pain. Things like anti-epileptics like gabapentin, carbamazepine, tricyclics, amitriptyline, duloxetine, and then you also have things like mexiletine, tramadol, and capsaicin. These have all been found to greatly help with the neuropathic pain in these patients. Just at the to close, there's a lot of research going on when it comes to these things, but I just chose two that I found particularly interesting. I just wanted to mention them. There's actually a study from UT Southwestern where they found 3 antibiotics, demeclocycline, cotetracycline, and monocycline, when administered together, were effective in reducing neuropathic pain. And how they do that was they bind to a receptor, the EPHB1, on the surface of nerve cells, which from previous studies was found to play a major role in the in nerve pain, and they actually bind to and block these receptors. So they actually were effective individually, but when combined at a lower dose, they were more effective.
Excellent.
And then another one was the stem cells. They're using stem cells to make pain-killing neurons. Basically, they found that when they inject these stem cells, they're able to migrate to the site of the nerve injury and heal the nerves, and also deliver some neurotrophic proteins to those nerves. So that's 2 exciting things. But like I said, there's so much research going on right now in regards to these, nerve pain and things, because it does impact the patient's life quite significantly.
Thank you very much.
Thank you.
Very nice, kind of a short, good summary. Just to say that neuropathy is becoming more and more recognizable. There's almost, there's kind of increasing prevalence of neuropathy for many reasons we don't know, probably environmental, chemical, people are living longer and so forth. So all of you will see patients with neuropathy, so-called peripheral neuropathy. Let me share with you the way I look at it very quickly. I look at it as once we get the history and we examine the patient, I look at neuropathy in terms of buckets. So there's a large bucket, big bucket in the United States, and it's very similar all over the world, diabetes. So that's the biggest bucket that we have, you can imagine. So the chances are the neuropathy, it's diabetes. So slightly smaller bucket in the United States, alcoholism. I think you mentioned it. And if you don't ask about alcohol, patient may not tell you. They may not realize that maybe drinking 3 or 4 glasses a night is important. And we, I don't know, some of you don't drink at all. I know for me, a half a glass of beers, that's it. I can't tolerate anymore once a month or something. But other people drink every day, and for them, that's kind of normal. Well, it's not really normal. So alcohol is a bucket too. And then the rest of the buckets get smaller and smaller. You mentioned the inherited forms of neuropathy. We don't use the word Charcot-Marie-Tooth as much now. We recognize that these are genetic disorders. We call them hereditary sensory motor neuropathy, type 1 all the way up to 9, some subgroups and so forth. So this is something to be aware of. And there are some some patients. We had a student here a couple of years ago who actually had the condition but didn't know it, and it was very evident. And I you know, we've had a lot of experience with neuropathy, so I knew right away that he had this, but I waited for the student to kind of come to me about this condition. But so he had hereditary sensory motor neuropathy type 3 and subgroups and so forth. Then there's another group that is related to nutrition, vitamin deficiency. And believe it or not, there are still people who are deficient in vitamins. And once you replace the vitamins, they improve. B12, thiamine, B6, pyridoxine. These are all things that we can measure. And then there are neuropathies secondary to environmental factors. Always ask about their jobs, exposure. India, for example, there are a lot of papers published on the sprayers, the folks who go into the fields and they use insecticides and pesticides. We used to use chlorinated hydrocarbons in the past. Then we moved to organophosphates. All of these cause neuropathy, by the way. So always take a history of not only the work, but also pastime, hobbies, etc. And then I think it's very important to remember the autoimmune, lest we forget. Many patients, after you work them up and you can't find the really underlying cause, turn out to be autoimmune. And one of the areas that we're very interested in is the small fiber neuropathy. These are C fibers. They don't have a lot of myelin. They're unmyelinated or poorly myelinated neuropathy. Could be very painful, mostly sensory, not so much motor, sensory, right? And we look at the possible causes, and then we look at treatment. And one of the new treatments is the IVIG, plasmapheresis, as you mentioned, and immune modulating drugs coming, immune modulating drugs as well. And that's kind of where we are. But if you think about it, if you first see somebody with neuropathy, it's overwhelming, like, what is this? But if you think about it in terms of containers, I like to think in containers, the big containers, all the way down to the small, the autoimmune, relatively small, perhaps also the paraneoplastic, relatively small, and so forth. Anyways, thank you very much. Very nice, very good presentation. We have new